You are currently the
That
only
is
person in
really
this
loud.
conference.
Holy Toledo. Hello, this is Yuko, and this is lecture number 5. We're going to cover personality disorders, mood disorders, which include suicide, and mood stabilization, and addiction and detox meds. So let's talk about mood disorders and suicide. Here's your lecture objectives. All right, so we know that there are two terms that we use to describe suicide. One is the word attempted suicide, and the other one is completed suicide. All right, suicide attempts are willful. They can be life-threatening. All right, they can be done because of revenge, because of guilt, because the individual actually truly feels that there is no other way out, because they are so engrossed with their personal physical and emotional pain. Suicidal ideations is a person who thinks about self-harm. I urge you to always take any suicidal threat seriously. As nurses, one of the questions we should be asking is, are you thinking of harming or killing yourself? If the answer is yes, then the second question you should be asking is, do you have a plan? We know that individuals with a plan that's organized have a higher propensity to be successful at suicide, whereupon somebody who may have a vague plan like taking a flight and jumping off of Mount Kilimanjaro tomorrow has a little bit of time for some sort of intervention to take place. So oftentimes, individuals who are anxious, can't sleep, substance abuse, chronic pain, maybe have a higher draw towards a suicide attempt. All right. We do know a lot of times they do have a lower threshold for emotional pain. Just because a person have some of the risk factors does not mean they're suicidal. So when we look at older adults, the typical suicide victim is a Caucasian male, single, 65 years of age or older, and Protestant. All right. So some of the factors can include the fact that they're socially isolated because, a lot of times they may be living out of state and their children are scattered throughout the other states. They may have just lost their loved one. They may be under a lot of financial stress and their health is declining or has declined, and they may feel hopeless. Most older adults who have committed suicide have visited their primary care physician the month before the suicide, and sometimes even that week and that day. All right, so it's real important that we recognize the symptoms and intervene. All right, so threats, overt statements, I can't take it anymore. I wish I were dead. Living is useless. I won't be a problem much longer. Nothing feels good and never will again. It's okay now. Everything will be fine. Always explore these statements. You can ask them, could you please explain to me in depth what you mean by that? All right? Don't try to guilt somebody out of a suicidal feeling, by saying things like, well, your religion prohibits it. What's going to happen when you don't go to heaven? Or what are your children going to do? Or what's your loved one going to do? Okay, so behavioral things, giving away prized possessions, making out a will, all right? The one thing here, exhibiting sudden or an unexpected improvement in mood after being depressed and withdrawn. If you have a patient who's been on the unit and all week they have been staying in their room and not participating in activities or getting up and getting dressed or eating meals, and you come to work and the next day they're like, hey, good morning, how are you? That's a big red flag. Put them on a one-to-one because now they've had time to develop a plan. And now that they've developed the plan, they see a way out. And so that heightens their spirits. So when you're assessing the lethality of a plan or potential lethality of a plan, how detailed is it? Do they have access to the method in which they decide to use, such as a patient who tells you that they're going to go home and shoot themselves, and you ask them if they have accessibility to any firearms, and they say, oh yeah, we've got a whole gun safe full because we're avid hunters. You need to make arrangements with either a family member or a friend to go over and get those weapons and secure them off premises under lock and key. Just be aware that oftentimes if you call the police, they will go in, they will confiscate the weapons, and chances are the patient may not get them back. So how lethal is the proposed method? We know that men tend to use more lethal means, such as shooting themselves, hanging. Women tend to do things a little more demure, such as ingesting pills, cutting their wrists. They did a study of women who had overdosed on pills and cut their wrists and asked them why they chose the method they chose. And the majority of them, over 75% of them, said it was because they wanted to look good in their casket. All right. So always, always ask, are you thinking of harming or killing yourself? All right. If they have a history of having had a significant suicide attempt, take them seriously no matter what. All right. If they have a history of family members who have either attempted or succeeded, take it seriously. I don't care if it's the 33rd time. Don't think that number 34 isn't going to be the one that's going to be successful. Red flags, going from sad to depressed to happy and giving away those possessions. Okay? So, is there a plan? Have they had adverse life events? Are they impulsive? Do they have poor judgment? Are they incarcerated? And again, do they have a history of exposure to suicide from family, friends, or peers? So, provide a safe environment. You do Q 15-minute checks or put them on a one-to-one. All right? You can do what's called a no self-harm contract, where you talk to the patient and you have them agree that before they will do anything, that they will come to seek out staff members. Just because they do a no self-harm contract does not mean they're going to abide by it. So don't get comfortable and think that's okay because they did this contract. You need to still watch them. So we can give them TCAs, tricyclic antidepressants. All right, so the brand name is here on the left. The generic name is here on the right. Don't forget, I will be asking you about the generic name. Now, the bad thing about the TCAs is that if the patient takes them in an overdose, they accumulate in the myocardium and then they cause fatal heart arrhythmias. So even though the patient may initially survive the overdose, they can die days later from the fatal arrhythmias. So some of these medications have dual use. Amitriptyline is used in low doses for an adjunct in pain control. The problem with it is that the very vivid nightmares. Tofranil and mipramine is also used for enuresis or bedwetting. Pamelor, nortriptyline, also used as an adjunct for diabetes and neuropathy. So you will need to know these slides as to have the FYIs or the precautions. These are tolerated better by most patients, but can cause orthostatic hypotension, so you need to get orthostatic blood pressures on them. Blurred vision, right? Constipation, dry mouth, that's because of the anticholinergic side effects. Urinary retention is considered an emergency, all right? And again, it can accumulate in the myocardium and cause life-threatening arrhythmias. Originally, they were developed as antipsychotics, but then they discovered that they actually worked much better as an antidepressant. So they may block the uptake of serotonin and norepinephrine. They can be sedating. They can also cause weight gain because they decrease carb and fat metabolism. There are sexual side effects, but they tend to be pretty transient. Rule of thumb, start low, go slow. All right, these are the serum serotonin reuptake inhibitors. They're the first-line meds for depression. The biggest problem with these medications, especially for men, are the sexual side effects. In fact, I had a student tell me that the way to remember that is that SSRI meant sorry, sex remains impossible. Okay, so vortioxetine, citalopram. Vortioxetine is fairly new on the market. Celexa, citalopram has been around. Citalopram and escitalopram are isomers of each other. Escitalopram may have a faster onset than other SSRIs and minimal weight gain and minimal sedation. Fluoxetine, oldie but goodie. Prozac can be used for obsessive compulsive disorder, bulimia, panic disorder, and it's good for patients with low energy because it tends to be rather activating. Sertraline also can be used for OCD, PTSD, phobias, panic, and premenstrual dysphoric disorder. All right, fluvoxamine, again, the OCD, vilazodone, paroxetine, oldie but goodie, good for panic disorder, more prone to discontinuation syndrome. So what happens with that is that a patient has been on an antidepressant for a period of time and they come off of the medication because they either miss doses, they can't get the money to refill them, whatever the case may be. They will actually end up feeling electrical shocks to their hands, their feet, and you will see them. They'll be standing there and they get brain zaps. They'll be standing there talking to you and all of a sudden they jerk like somebody has just shocked them. And when you ask them if they feel like they've gotten shocked, they'll tell you yes. But that is called antidepressant discontinuation syndrome or antidepressant withdrawal syndrome. Okay, so that's the shocks. There's sexual dysfunction with these, nervousness, insomnia problems. All right, it's a drug of choice for depression because it has low serious side effects. Okay, fewer anticholinergic side effects and increases the mood quicker than the TCAs. All right, better tolerated, safer in an OD, can cause weight gain, anxiety, decreased appetite. A lot of the side effects, except for the sexual one for men, are pretty transient. Vortioxetine may also help to improve cognition because it may affect dopamine. The thing you need to know about all of the psychiatric medications, all of them, is that the patient cannot have grapefruit juice or grapefruit products. All right? It's also going to take medications approximately anywhere from 2 to 8 weeks to activate because the patient has to build up an adequate serum level. So sertraline tends to be activating, so good for people who tend to be kind of sluggish. All right, so citalopram may flatten the affect. Better for clients who are activated by other SSRIs. Have them move slowly with position change so that they don't get hypotension. Okay, so we talked about the paroxetine and discontinuation syndrome. Vilazodone, the main thing about that one is bad GI side effects, so make sure the patient takes it with food. Okay, so we talked about the antidepressants needing to be tapered. If they've been off their antidepressant for a prolonged period of time, you're going to start them on fluoxetine because fluoxetine has an extremely long half-life. Bupropion, also known as Wellbutrin, can be given with an SSRI to prevent the sexual side effects. All right. Make sure that the patient knows that if they combine alcohol and the medications such as the benzos, opiates, and barbiturates, that it's going to worsen depression when the brain attempts to reach homeostasis. Okay? All right. SNRI serum, norepinephrine reuptake inhibitors. All right. Deseril, trazodone. If you have a patient who has a history of abusing their medications and suicide attempts, specifically TCAs, then trazodone is going to be the medication you want to send them home on. Because if they overdose on it, it's just going to make them sick. Also, trazodone can be used at HS to help people to sleep. All right, venlafaxine increases the release of norepinephrine, serotonin, right? Dopamine, glutamate, acetylcholine, and histamine. Oh boy, affects quite a bit. but it can cause hypertension and GI upset, may cause cardiac problems and an OD. Duloxetine is more balanced for serotonin and norepinephrine. Wellbutrin SR, bupropion, what was so good about this medication it's also known as Zyban, which is given for smoking cessation. Same medication as this antidepressant. This one costs about $1 to $5 a pill, whereupon as Zyban, it was $15 to $20 a pill. So the thing you need to know about bupropion, it is energizing. However, it can cause seizures in individuals with eating disorders, and it also acts as a booster for the antidepressants. All right, so again, watch for hypertension, okay? MAOs, monoamine oxidase inhibitors. There's only 3 of them, thank goodness. This alert you need to look at. The patient needs to have a washout period of anywhere from 2 to 4 weeks before other antidepressants are introduced. All right, you can never mix them with SSRIs or TCAs. All right, they have a fatal link to Demerol. Avoid dextromethorphan, which is found in cold and hay fever preparations. Right. All right. The problem with an MAO is if you get a patient who's taking them, they have to go on a tyramine restricted diet. So you need to call dietary and let them know that they can't have tyramines. So the bad thing is, here's all the foods that have tyramine. So you're going to find that there's anything that's good and anything that's fun. Nothing aged, okay? So they can't have cheeses, they can't have yogurt, sour cream, steaks, roast beef, all right? No pepperoni. Boy, what's a pizza without that, right? Be careful with soy sauce, yeast, all right? If they get foods high in tyramines, it can cause a hypertensive crisis that leads to increased intracranial pressure, coma, and death. So make sure that you're familiar with this list, okay? All right, that seems to be it. Let me get to the next slide. All right, let's talk about substance abuse. Well, that didn't help, did it? All right. So here's your objectives. 3 C's of addiction: craving, continued use despite consequences, loss of control. Another C is cognitive impairment. Again, you only have so many brain cells to burn out, and unfortunately, when you get to a certain point, there's no coming back. Non-substance addictions: gambling, sex addictions, cell phone sexting, a little retail therapy there, shopping. All right, we know that dopamine plays a role in pleasure and pain, okay, and also in all addictions. Drugs of abuse affect the limbic or the reward system of the brain. Okay, when you use for the first time, let's say you go to the casino and you win at the slot machine for the first time, you get a big rush of dopamine, which gives you intense pleasure. Your neurons aren't able to regulate that dopamine, and then all of a sudden the dopamine can't stimulate the reward center because it's going to take more and more to do what it originally started out to do. All right, so then the cycle of tolerance begins and dependence and addiction occurs. Difference between substance abuse and substance addiction: abuse, you can use it, but you don't have a physical or psychological craving. Whereupon addiction and dependence, if you don't have it, then you can't function, and it can be fatal. So, substance abuse and DSM-5, it's a problem when it interferes with your ability to fulfill your obligations at work, home, or school. All right? It can affect relationships, affect your job. Okay, so here are the meds that we use. These medications are used as to manage sobriety. All right? My favorite medication is naltrexone, also known as Revia. I like it because it reduces or eliminates alcohol craving, but it has a dual purpose. You can also use it for opiate dependence as well. Acamprosate, also known as Campril, helps the patient to abstain from alcohol. Ironically, the beginning dose of acamprosate is 666. So if you hear the doctor say to you, let's give him the 666, that's what they're talking about is the acamprosate. Topiramate, Topamax, is an anticonvulsant. It helps to decrease alcohol cravings, not as effectively as naltrexone, but the bad thing is that because it's an anticonvulsant, if it's stopped abruptly, it can lower the seizure threshold and put the patient into grand mal seizures. Disulfiram or Antabuse is kind of going by the wayside because they can still drink when they're taking it. However, when the alcohol combines with the disulfiram, it combines into some sort of metabolite that's found in rat poison, and it makes the individual extremely sick. All right. Alcohol-related death is the third leading preventable cause of death in the U.S. So let's take a look at some of the other things that can be used and abused. Stimulants, common signs, dilation, dryness of the oral nasal cavity, and excessive motor activity. All right, cocaine and crack takes effect in 4 to 6 seconds, but it takes 5 to 7 minutes for them to get the high. It acts as a stimulant and also as an anesthetic. Okay. Withdrawal symptoms, lethargy, nausea, vomiting, paranoia, sweating, and chills. So opiates, main one here, they get a runny nose. They get lacrimation, in other words, their eyes tear up. All right. Muscle aches, really bad. And then they get really agitated and they get very, very restless. They can't sit still. So what can we do? We can give them things like methadone. Methadone is a synthetic heroin. It was designed to pull heroin addicts off of heroin, but now we get them addicted to the methadone instead. Methadone is the one medication that just kind of boggles my little brain because I usually get the patient who's on 100 milligrams of methadone, and of course the pharmacy in the hospital only has 5 milligram tablets. I just cannot fathom, I cannot figure out. It doesn't make sense to me to pour 20 5 milligram tablets to make 100 milligrams. I will always keep them in the packet. I will take it to another nurse and I will ask, please check the dose and tell me how many tablets I have to have. Because giving somebody 20 of anything just scares me to death. If I have to give 2 or 3 tablets, I get a little antsy. But 20? Oh, no, no, no. Okay, we talked about naltrexone. Clonidine catapris is a very powerful antihypertensive, so you've got to watch them for postural hypotension. Buprenorphine Subutex also helps to block the signs and symptoms of opiate withdrawal. Very, very effective, however, is extremely expensive. A lot of hospitals don't carry it on their formulary. Marijuana has hallucinogenic and depression properties to it. We do know that long-term use can cause difficulty concentrating and memory loss. Okay, new street drugs, carfentanil, also known as Wildanil. It's a spin-off of fentanyl. It's one of the most potent opiates known. It has a quantitative potency approximately 10,000 times that of morphine and 100 times that of fentanyl. Okay, activity in humans starts at about 1 microgram. All right, it's known as Wildanil because it is an elephant tranquilizer. All right. All right. There's another one called sufentanil, which is 10 to 20 times less potent. Okay, still 5 to 1,000 times the efficacy of morphine per weight. Okay. So here's how much heroin it would take to kill an adult. Here's how much fentanyl it would take to kill an adult. And here's how much carfentanil it would take to kill an adult. Remember that this picture is enlarged. This little carfentanil thing is about the size of a pinhead. That's how much it would take to kill an adult. In elephants, they use 13 milligrams to get the elephant down. All right, other drugs. Crocodile, IV derivative of morphine. Oh, it's made with a wonderful concoction of codeine, iodide, gasoline, paint thinner, hydrochloric acid, lighter fluid, and red phosphorus. Those are all important things to make sure you ingest, shoot up into your veins, right? All right. Here's some wonderful pictures of what it does to your skin. It's called crocodile because they get scale-like skin and then they get tissue damage. Look at this person's legs here, this individual's arms. Look at this. It's eaten away at the muscle mass. I could not imagine. Concrete, also known as gray death. It can be injected, swallowed, smoked, or snorted. You cannot touch it without gloves. Comprised of heroin, fentanyl, carfentanil, and an opiate known as U-47700. Can kill users in a single dose. Avoid contact with bare skin, and the reason is because it can cause respiratory arrest. All right. Then there's pink, which is the U-44770. It's a Schedule I drug. It's actually legal, okay? But it doesn't have any use. So it's a synthetic opiate, and it causes a feeling of euphoria, all right? But it can also sedate and cause respiratory depression. And that's what it looks like. To me, it looks like powder. All right, scopolamine, devil's breath, creates a zombie-like state, and the patient has no control over their actions. It's derived from the flower of the borracho shrub, common in Mexico. All right, the seeds can be powdered and then extracted, and it can be present in Jimson weed. I have no idea what that is. It's an anticholinergic medication, and OD can lead to seizures, coma. Okay, we use scopolamine as scopolamine patches, which go behind the ear, and they're used for motion sickness. All right, biologically, we know that genetics plays a role in addictions. Okay, alcohol produces morphine-like substances in the brain. Psychologically, a lot of individuals who are addicted have low self-esteem. They can't defer gratification. They may not be able to communicate effectively until they get a couple of drinks in them, and boy, oh boy. Or it could be because it's peer-oriented. All right, so what are the effects? They get neuropathies. They get what's called alcoholic myopathy. It's a vitamin B deficiency. They get muscle pain, swelling, weakness, a reddish tinge to the urine, and a rapid rise in the muscle enzymes. Okay, when it becomes chronic, they get that wasting in their skeletal muscles. Ortiquees and Korsakoffs, make sure you guys know this. Most serious form of thiamine, vitamin B1 deficiency. Korsakoff is the confusion and loss of memory and the confabulation or the making up of stories that alcoholic patients do. It enlarges the heart. They get esophagitis, oftentimes because they're vomiting. They get gastritis because, alcohol does not belong in your stomach and it's an irritant. One of the things when I was in the military, we saw a lot of the men who were stationed over in Asian countries such as Vietnam and so forth, their alcohol is formaldehyde based. Pancreatitis is very, very painful. If it's chronic enough, it can lead to type 2 diabetes, where they have to take insulin. And of course, hepatitis, cirrhosis. That liver looks horrible. portal hypertension, esophageal varices. So much vomiting, they wear out those vessels in the throat and they get very, very thin in their walls, and then just one time later they pop. And boy, I'll tell you, if you've ever seen anybody bleed to death with an esophageal varices, they can bleed to death within a matter of minutes. Hepatic encephalopathy, we talked about the ammonia levels. Normal is 15 to 45 micrograms per deciliter. That's why it's important to check the ammonia level to make sure that their level is not elevated, because as I said, it will go to the brain and it will cause irreversible brain damage. Then they get leukopenia, thrombocytopenia, so they become susceptible to infections. Alcohol intoxication lethal level is at 400. Alcohol withdrawal occurs within 4 to 12 hours after their last intake. So, what are the symptoms? Alcohol withdrawal peaks in 24 to 48 hours. Okay? If they have a history of grand mal seizures, that's probably going to take place in 7 to 48 hours. Alcohol delirium is called delirium tremens, Tremens. It's a medical emergency. Peaks 2 to 3 days after their last intake. When they drop down, they're the ones who are going to come in with a blood alcohol of 600-700. When they drop down to 400, they're in trouble, right? When they have a history of DTs, they need to go to a medical unit, not to a regular psych unit. All right, so sedative and hypnotic and anxiolytic dependence, they're CNS depressants. A lot of them have a long half-life, so withdrawal from these doesn't take place in 48 to 72 hours. It can take place in weeks. So intoxication from amphetamine, cocaine, they get euphoric, then their affect gets blunted. When they're withdrawing, they can't sleep, they're agitated, their muscles hurt, they're miserable. All right. Caffeine. We even have shrines built to caffeine, known as Starbucks and the Human Being, and now we have these Dutch Brother things. Caffeine consumption at 250 milligrams or greater is considered intoxication. Okay. Symptoms: restlessness, arrhythmia, tachycardia, withdrawal, fatigue, depression, irritability, headache. When they have to withdraw from nicotine, dysphoria, irritability. So as I said before, think about somebody who goes into the psych unit and they're withdrawing from caffeine if they drink coffee, nicotine if they're a smoker, their street drug, and if they're drinking alcohol, they've got to detox from that. So that's 4 substances at once. That's a lot to ask of them. Inhalants. Okay, so when people use inhalants, that's called huffing, Huffing. So what they do is they take and they put something that tends to be like flammable, like airplane model glue. They put it into a container and then they inhale it. And when they get intoxicated on it, they become uncoordinated. They get nystagmus, that's where their eyes bounce. They get psychomotor retardation and stupor. They just basically sit there and drool. So opiates, we've recognized there's a big problem here, and now we're trying to get people off of opiates. Opiate intoxication can lead to a coma or death. Hallucinogens, spices, that formula changes all the time. It's back, by the way. Salvia is an herb that you can buy like in a health food store to season your roast and so forth. And for some odd reason, some brave soul decided that they would smoke it, and it gives you a more intense high than that of LSD. Bath salts, constantly changing as well. Hand sanitizer, big one amongst adolescents. They somehow do some sort of filtering because a lot of hand sanitizers are 70 something strength of alcohol, and then they drink it. Intoxication within a few minutes to hours. They get perceptual alteration, depersonalization, derealization. All right. Then they can get heightened response to colors and sounds, paranoia, elevated blood sugar, okay, the chills, pupil dilation. All right. Other hallucinogens, PCP. I don't see that around as much anymore. Ecstasy, is a serotonin modulator, makes you feel good and warm and fuzzy. Sherm is marijuana laced for formaldehyde. A lot of people who take one hit burn out their brain forever and ever. Gen Chem originated in the prisons, and it's where you defecate and urinate into a collection container, such as a jar. You put on a collection device, such as a glove, and you set it out in the sun, and you let it ferment. You then take off the glove, and you inhale the methane gas from that. So, yeah. All right, so they can get impaired motor coordination, boy, I've got verbal incoordination, impaired judgment, dry mouth, tachycardia, and it can last for 8 to 12 hours. That's with cannabis. So, assessment tools, cage questionnaires, SIWA, which we're familiar with, SINA, and the COW. The COW and the SINA are basically the same thing. So the cage questionnaire asks, do you feel like you should cut down if people annoyed you by criticizing your drinking? Have you felt bad or guilty about your drinking? Have you ever had to have an eye opener? Okay. Dual diagnosis. Remember, in psych, dual diagnosis means that there is a psychiatric disorder and also a chemical dependency disorder. Okay, so what do? Provide substitution therapy, provide a safe and supportive environment. All right. Educate them about their chemical dependency, about the symptoms, help them to try to understand the causes. We can refer them to outpatient things like Alcoholics Anonymous. It's an old program. It's over 50 years old, but it's very, very successful. All right, and that's it. Let's get on to our last one, which is personality. All right. Oh boy, so this one still cut it off. All right, personality traits are enduring. They have a way of interfering with the way a person perceives, relates, or thinks about the environment and oneself. Between 9 and 16% of the population will meet it. With the population diagnosed with a personality disorder, 30 to 50% have another disorder. Okay. They tend to be inflexible, maladaptive. There's no single cause. What you also need to know is that there is no medication effective for personality disorder. All right. Disorders usually are present from infancy and emerge in adolescence. So, your personality is how you deal with the world, right? We all have a different type of approach. We're all different. All right. So, you have to have 3 qualities in order to be able to function adequately: a stable and realistic sense of self, a way to be able to interpret socialization and situations and understand how you move and react to others, and to be altruistic or have altruism, which is the capacity to serve for others. All right. Oftentimes, the contributing factors is they may have lived through some sort of childhood trauma, such as sexual abuse, for borderline personality disorders and antisocial personality disorders. Culturally, certain groups are at risk: Native and African American youths, young adults, individuals who are divorced, separated, or widowed. Low rates occur in Asia, also amongst Jewish families and families where there may be very strong ties. All right. So the patients don't see the behavior as the problem. They see that you are the problem. And sometimes they take a lot of pride in the way they act. All right. So they want to be close to people, but they can't because their big thing for borderlines is avoidance and fear of rejection. All right. So they have a capacity to get under your skin. Oftentimes they may be the martyr. I'm the only one who can do this or will do this. They may be socially isolated. Oftentimes they may have bizarre behaviors. They may exhibit outrageous and troublesome behaviors. And healthcare professionals may feel confused, angry, and frustrated with them. All right, so they have very poor ambivalence and impulse control. They do this ego weakness where they don't know where they begin and you end and vice versa. So they also do what is called splitting. When you split, it's like you pit mom against dad and vice versa. All right, so the blurred personal boundaries, their needs are experienced as rage. Sexuality and dependency are confused with aggression, and they have very intense and inappropriate behaviors in relationships. All right, so borderlines tend to split. They also tend to be very, very into self-mutilation and prone to suicide attempts. All right. The narcissistic individual oftentimes is attention-seeking, they're grandiose, they're antagonistic. They also do the splitting, but they also are very, very exploitive and completely lacking of any type of empathy. All right, so these are clusters. Cluster A are all the mad guys, okay, the personalities that are paranoid, schizoid, or schizotypal. They're odd or eccentric. Cluster B are the bad boys. They're dramatic, emotional, erratic, so they're antisocial, borderline, histrionic, narcissistic. Cluster C are all the sad guys. They're the ones who are anxious and fearful, so avoidant personality, dependent, and OCD. All right, paranoid, doesn't trust anybody. Oftentimes we see this with patients who are schizophrenic, more common in men than it is in women. All right. The general population, about 3 to 7.5% for schizoid. All right. They cannot form personal relationships. They can't respond to others in a meaningful and emotional way. They are dead serious all the time. They cannot get silly and have a good time laughing. And it may be because their parents were unempathetic, not nurturing. Schizotypal, graver, they're aloof and isolated, apathetic, but they do have a true psychological or belief system that's in psychosis. So they do the magical thinking, the ideas of reference, and so forth. All right. So theirs is a neurochemical imbalance. All right. All right. Could be though the family was not very comfortable with any type of closeness. The family may have been very formal. All right. Antisocial, big one. They have total disregard for the law. They are very exploitive. They're only about themselves. They deserve special treatment because they are who they are. All right. It tends to be more prevalent in men than it is women. All right. Very cold, very callous. And maybe because there weren't any parents during their first 5 years of their life or they had a history of ADHD or conduct disorder. All right. They may have grown up without parental figures from both sexes. They may have lived in extreme poverty. They may have been the youngest child who's always rescued every time they get in trouble. Okay. So they have intensity and instability as part of their behavior. They tend to be depressed, okay, and clinging, and distancing, so they push and they pull. Histrionic, oh boy, very colorful, very dramatic, very gregarious, extroverted, more common in women than it is in men. Okay, they have difficulty in relationships, could be hereditary or it could be learned, but we do know possible link to serotonin and noradrenergic systems. Narcissistic, again, all about me, self-centered, exploitive. They're actually very engaging people. Okay. Could be because the parents were narcissistic themselves. Avoidant, doesn't want to do anything that puts them in a position of power. Could have been because parents are rejecting and critical of them. Okay. Dependent, lacks self-confidence, their posture, their voice, their mannerisms. Okay. More common among women than it is in men. All right. So oftentimes they will do whatever they can to try to make friends. All right. And it could be because they couldn't detach as an infant. Passive aggressive, has passive resistance and general obstructiveness. They can vent their anger and resentment in a very subtle way. Oftentimes they're the martyrs. They're the ones who had to do stuff because nobody else would do it, and they were the only ones. Okay. And it could be because they weren't able to achieve autonomy as a child. But this one can be tied to serotonin. All right, so what do? We need to make sure we set limits and we enforce those limits, and that needs to be with every shift. There's always the staff member who decides that they're going to be their friend, and that totally disrupts everything. So everybody has to be on the same page, having the same reactions in the same manner. Most importantly, got to talk. You've got to communicate because these patients are going to try to split. And if they cause an argument between the two of you, they've won. Okay? So set the limits. Okay? Don't let them try to make you feel guilty or clinging. Don't let them pit people against each other. All right? You've got to set boundaries and consequences and reinforce those consequences. Okay, you need to avoid accepting gifts, doing special favors. So we can do interpersonal psychotherapy, psychoanalytical psychotherapy, milieu, or group therapy, or cognitive behavioral therapy. All right, and that is it for lecture number 5. Yeah!